Welcome to the deep dive. Have you ever experienced that kind of persistent, nagging ache, maybe deep in your hip or groin, and it just won't quit? Today, we're taking a really insightful deep dive into Iliopsoas tendinopathy. It's, well, surprisingly common, but often a pretty tricky source of discomfort.
Yeah.
Our mission is basically to demystify this condition. We're focusing on the iliopsoas muscle and, the structures around it so you can truly understand what might be going on.
Exactly. And this deep dive should help clarify things because while it's usually very treatable, it can look clinically almost identical to other issues. That can be frustrating.
Right.
So you'll gain some clear insight into its causes, what it actually feels like, and the different ways we approach diagnosis and recovery.
So if you've ever felt that kind of elusive front of the hip pain, let's pull back the curtain and try to understand it a bit better.
Oh.
Okay, so let's break this down. We're talking about the iliopsoas muscle.
Mm-hmm.
For those maybe less familiar, it's actually two deep muscles, right, that join up.
That's right. They join to form your main hip flexor, the sort of powerhouse muscle group that lifts your knee toward your chest.
Gotcha. And we're zeroing in on how its tendon, that strong cord-like bit connecting muscle to bone, can get inflamed or irritated.
Right. That's the tendinopathy part.
Okay.
And what's truly insightful here, I think, is that while, a big acute trauma is less common, this condition, whether it's the tendinopathy itself or maybe bursitis.
Ah, bursitis. Okay. Inflammation of that little cushion sac.
Precisely. That fluid-filled sac that reduces friction. Both conditions typically result from overuse injuries. Think repetitive hip flexion and extension.
So not just for athletes then?
Not at all. I mean, think running, kicking, sure. But even something as seemingly harmless as, prolonged sitting can be a major culprit.
Wow. So it's often linked directly to the very movements we do every day. Right. Or even just sitting still. That's quite a revelation for many, I bet.
Exactly. One proposed mechanism involves a sudden hyperextension, like stretching back quickly when the hip is flexed. Or it could be the muscle or the bursa just kind of snapping over the top of the thigh bone. The femoral head or the joint capsule itself. Sometimes it rubs against a bony bump on the pelvis, too.
The iliopectineal eminence.
That's the one. And this all sort of highlights why this particular area, even though we use it all the time, becomes so susceptible to problems.
That paints a clearer picture of how it can happen. But, for our listeners wondering, does this sound like me? What are the actual sensations, the specific symptoms?
Well, patients often report pain right at the front of the hip, the anterior hip. Sometimes it feels deeper, maybe more in the groin.
Okay.
And it's usually aggravated by physical activity, things like climbing stairs, running, kicking, even just getting up after sitting for a while.
Right.
The pain might be gone when you're resting, especially early on, but then it can progress. When a snapping sensation is very common.
Snapping, like an audible click or just a feeling?
Can be either, yeah. Particularly common in athletic individuals. And the pain can even radiate, sort of shoot down the thigh towards the knee.
That sounds incredibly painful and frankly frustrating. Given those symptoms, what are doctors actually looking for to confirm it? And what makes it so challenging to pin down?
Yeah, that's a crucial point. The symptoms overlap quite a bit with other conditions. Hip joint arthritis, labral tears, hernias, stress fractures, lots of possibilities.
Okay.
So, on physical exam, clinicians are looking for very specific tenderness, usually just distal so, a bit further down from the inguinal ligament, that band across your groin, basically where your thigh meets your torso.
Right.
And then there are special physical tests, like the Thomas test or the Eli's test, maybe the prone hip extension test. These help assess hip flexor tightness or irritation.
So, after the hands-on exam, what about imaging? What tools help confirm it?
Good question. Standard hip x-rays are often done first, but they're usually normal. They're mainly for screening out other bone issues.
Makes sense.
MRI is typically the most informative. It can show findings like a distended swollen bursa or fluid around the tendon, the paratendinous fluid.
Okay, MRI is the key then.
It's very helpful. Ultrasound is also valuable, though. It can show similar things, and it's really useful for guiding injections accurately right to the spot.
So, once it is identified, what's the typical path to feeling better? Sounds like there's definitely hope for recovery.
Oh, absolutely. If we connect this to the bigger picture, the good news is that non-surgical treatment is usually linked with highly favorable outcomes.
That's great to hear. What does that involve?
Typically, it starts with relative rest, not complete immobilization, but avoiding the activities that really aggravate it. And physical therapy is key.
PT focusing on
Specific exercises. especially eccentric strengthening exercises.
Right, strengthening the muscle as it lengthens.
Exactly, like slowly lowering your leg against resistance, and also working on hip extension stretches.
Hmm.
This usually happens over, say, a 6 to 8 week period.
Okay.
And often NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen, are used to help reduce inflammation and manage the pain in the meantime.
And what about those cases that are a bit more stubborn, need a bit more intervention?
Well, Iliopsoas bursa injections, often guided by that ultrasound we mentioned, can be used. Sometimes just for diagnosis, like if the pain goes away after the injection, you've confirmed the source.
Ah, clever.
And they can be therapeutic too, providing longer-term relief with corticosteroids. Surgical intervention is really quite rare.
But it's an option if needed?
It is, as a last resort. It might involve techniques like tenotomy, which is basically cutting or releasing part of the tendon, or maybe lengthening it to reduce tension.
This deep dive truly highlights how really understanding the specific mechanics of your own body can lead to much better outcomes, can't it? Especially with these persistent, sometimes the kind of mysterious aches.
It does.
It's a testament to how interconnected everything is.
Indeed. And what's fascinating is how conditions that feel really complex, maybe even debilitating, can often be resolved with quite targeted non-invasive approaches. It really emphasizes the body's incredible capacity for healing, with the right support.
So, what does this all mean for you listening? Well, next time you feel that persistent ache, remember that these deep dives, this kind of exploration into your body's intricacies, can reveal surprising clarity and hopefully effective pathways to recovery. Keep exploring, keep learning, and keep asking those insightful questions about your own well-being.